we're getting into what I think is one of the most important things that we're starting to see new ways that doctors and patients are communicating, and or not communicating because they're doing it passively. So I'm really excited about this next session because one of the questions I get, especially from startups, is, how do we work with the hospitals, and how do we, get our products into trials and things like that. So I think this session will be extremely enlightening for those of you that are interested in that, as well as, what are they doing? So we have two of the leading healthcare providers here, kind of sharing, hopefully, some cool insiders' secrets about what they're doing. So I want to introduce to you Greg Caressi, who's going to be leading this next session. He's the Senior Vice President of Healthcare and Life Sciences from Frost & Sullivan. And so he is going, you guys can all come up on stage, sorry. He'll introduce you to the other two speakers. Greg's New Year's resolution is to help find a cure for pilotitis. So he'll be able to explain that to you right now. Thanks.
Well, I have two of the clinicians who are going to help me find that cure. Pilotitis is the fact that in digital health we've done thousands of pilots of all types of digital health solutions, and we haven't had that many deployments and widespread, other than things like EMR, and, especially when we're looking at patient-facing or consumer-facing. So we'll hopefully give you the answer to that question, or at least some clues on how we can resolve that issue of pilotitis. So we have with us here two CIOs from two leading healthcare organizations, both very progressive, should be able to offer us a lot of insights. So we're just going to jump right in without full introductions to both Pravene and Darren. Okay, so first off, obviously, you guys are part of the buyer communities, right? So you have some of the dollars, and I'm sure a lot of the audience is very interested in trying to understand, what are some of the initiatives that your organizations are looking at? How are you looking to better your organizations through the use of IT? What are some of the things that are driving those investments within your organizations?
Well, there's so many interesting problems that we want to solve right now. I would say at the top level, interacting with the healthcare system is just way too complicated. And that complexity manifests itself in the clinical encounters, and also in just the transactional stuff, the scheduling, the financials, paying your bills, deductibles, copays. We want to focus on simplifying this complexity, eliminating it where we can, masking it with a better user interface whenever that's possible. So we're working hard on the clinical side on taking some of these encounters and experiences where patients have to come to us and asking, do they really need to do that? Can we do things virtually? Sometimes it's low-tech solutions, just let an encounter happen by telephone. And then sort of moving up, we have video visit capabilities, some high-fidelity telepresence types of encounters. We have asynchronous photo-based encounters for things like skin conditions. And templated follow-up visits. So we're really trying to kind of run the continuum of making that interaction simpler. And then on the sort of administrative side, we want you to be able to do things that sound simple but are hard for us to execute on. So be able to make all of your appointments and any kind of scheduling interaction done online seamlessly, managing the payment side of things, and getting this stuff to interact with your regular life in a way that's smoother. The last thing I would say is that I think there's a very interesting problem that, that seems to come up as we do design thinking and talk to patients, which is people want to know, am I okay? I have a new diagnosis. How worried should I be? I have an acute illness. Am I healing in the way that's expected? I just had a procedure. Is this normal? So that problem is one that we want to work on, and we want to solve it without introducing additional burden into an already kind of burdened system. So what are the light ways that we can provide appropriate reassurance, let you as a patient know how you're doing, and not sort of tax the system unnecessarily with visits that aren't otherwise needed. So that's some of the problems that we're working on.
Okay, so one, very patient-facing, it sounds like, for a lot of the work that you're trying to do. How do the clinician side adapt to not having the patient come in front of them as often?
Well, it's been working well for us, actually. I think we've done this in a way that we call this sort of approach our clicks and bricks, because we are a healthcare delivery organization. We are not an online prescription writing company. And we want this to work in a way that people who trust us for their healthcare can know that when they have this experience online, if it needs to turn into something else, a diagnostic test, a procedure, a hospitalization, that's part of an ecosystem where that information is going to work right. And so for our providers, we've built that into the workflow. All of these things fit into the same electronic health record tools and workflows. So they've adopted this well. And it turns out that so far we have very high provider satisfaction and patient satisfaction with these kinds of encounters.
Okay. So Darren, what are some of the problems you guys are trying to resolve?
Well, there's a lot of problems, but along sort of similar themes, I sort of put them in sort of the two buckets. There's sort of the efficiency and sort of the access and the convenience piece, which Pravene touched on well, and I'll come back to that sort of in a second. But I think the larger piece for us is we're really trying to, for the first time, trying to sort of reinvent the health system, to really begin to sort of think of ourselves as not just the place that you come to when you're sick. And so, you know, one of our primary challenges essentially is that our interaction with our patients, interaction with sort of our customers at the end of the day typically happens probably at the last and wrong moment. And what can we do to sort of bring up sort of that care far earlier sort of in the continuum? And so building on some of the points Pravene raised, it's a lot of things of revisiting the touch points. And so when we sort of take a look at our interactions with our patients, we discover that really there's a lot of them that we really only see once a year or twice a year or on a very sort of episodic basis. What do we need to begin to do to engage with those same groups of patients, especially some of those chronic and acute patients, to sort of interact with them on a sort of more regular basis? And as we start to dissect that and sort of break that down, it really comes to a whole new set of types of interactions. And it's not really practical from the patient expectations and convenience perspective to sort of want to see that by driving in, finding a parking space, and coming sort of into the building. But it's also not practical even from sort of a volume and access perspective. And so that's leading us to lots of new ways. Some of those ways are as light as perhaps experimenting with some apps and some sort of, sort of light dialogue that goes back and forth between provider offices and the patient. And some of them is larger scale in terms of video visits and things sort of along those lines. But our hope is that as we can sort of grow that continuum and sort of get more of our patient touch points outside of the traditional, we'll actually get the scale that we need to really begin to focus on the wellness side.
So one of the things I didn't hear in those two discussions, which are all great, very enlightening, but we didn't talk about reimbursement. So we hear a lot of provider side unwilling to move forward with certain digital health tools because they're not reimbursed and waiting for reimbursement on monitoring tools and others. How big a role does that play in the decision making in terms of some of the technology tools you're trying to bring in to that patient care continuum?
I think there's sort of two sides to the reimbursement I think you have to sort of break down, and without sort of getting sort of too much sort of into the weeds of sort of healthcare reimbursements, there's sort of the fee for service, the sort of the episodic way in which you sort of show up, you do something, you get paid for that thing, and then at the other end of the spectrum is sort of this sort of risk-based sort of idea where you're really sort of getting paid for sort of a bundle or sort of a larger sort of spectrum of care. I think what is happening within healthcare, regardless of whether providers or patients, frankly, are ready for it, is the world is moving more towards sort of a risk-based payment. And as that begins to materialize and take place, it brings into play new models. And so as an example, it creates new incentives for large healthcare systems not to want to see their patients for the first time when something's not going well in the emergency room. You'd want to see them much earlier, and if that means that you have to sort of invest in some technologies or invest in some products, and frankly these days a lot of it is sort of service lines and labor, those begin to make more sense, whether they're reimbursed with a code or not, because we're sort of going towards this larger piece. So you're already thinking in that and
making decisions based on that capitated care model in reality, or at-risk model.
Absolutely.
Great.
Yeah, I think Darren said it well. I would also add that, at a place like Stanford where we have a lot of specialty care, we have access challenges. So anything that we can do to make sure that the right patient is getting in to see that specialist and sort of decant those other visits into a different format where value is provided, but not necessarily in the same form is especially helpful to us. So we think of it that we have a kind of experimental ecosystem. We have 10,000 covered lives in an ACO. We have employer on-site clinics where we have special contractual relationships. We have 1 million outpatient visits a year. So we can test these kinds of innovations in these different settings across the system of care that we have.
Okay, great. So we have a lot of vendors at CES, of course, and probably a number in our audience. One of the questions I want to ask is, what are the things that you look for in a vendor partner? What makes an ideal partner, and what are some of the barriers in those vendor relationships, or maybe in the approach sometimes from the vendor side, that are hard to overcome or challenges for your organization?
Well, we love the interactions we have with vendors, and we have a lot. I think partnerships, I'd say a few things. First, we're looking for a partner that understands healthcare, and either through experience or a willingness to embed themselves with us in the operations of healthcare, because it's such a complex system. And so when a vendor partner comes to us and says, this problem is really easy to solve, often that's not the right way to begin the conversation. We know the problems are hard. So someone that has an appreciation for the complexity of the system or is willing to get that appreciation, of course, working on the right problem. I mean, there's often a huge mismatch there that it may sound like an interesting problem, but it's not the problem that we're interested in solving, at this time, or we may not know that we have that problem yet, and we need to wait a little longer until we discover that we have it. And then we need vendors that are the right size, big enough to put some muscle behind it, but not so large that that the sort of healthcare effort can't compete well within the company. So that, I think that's what makes, and we've had some great successes sort of applying those thoughts. We've had some partners that have worked really well with us, and what we want to do in these relationships is, create shared value. And often we put an awful lot of energy into making these products and services work in our environment, and they may not be ready when they start, and that's a journey we have to go on together.
Okay. Anything?
Yeah, for us, I think sort of our interesting sort of lessons learned is, I think people have this fascination with healthcare. They sort of read sort of the big numbers in terms of how big the total market size is, and I think it sort of entices a lot of people to sort of want to jump in, which frankly at a high level is wonderful. I mean, I think we need a ton more innovation. It would be great if we have sort of more products sort of pouring into healthcare to sort of solve some of our problems. I think the challenge, and we sort of try to work with vendors to sort of understand this, is ultimately the real total market size that we're looking to tackle. And so, healthcare is big when you boil it down to providers, and you boil providers down to hospitals, you boil hospitals down to sort of a very specific solution. Really making sure sort of the vendor is really sort of committed to wanting to solve the problem for that segment. And frankly, I think that the temptation in entering healthcare is that it's going to be easy because there's going to be a lot of low-hanging fruit. But generally, we have some really sort of upfront heart-to-hearts with our vendors early on to make sure they sort of understand that it's not the type of vertical that you could easily get into and maybe bundle with public services and government and maybe a few other things. It really is going to be a vertical that you're going to have to put a lot of very dedicated effort. And if there's a willingness to put the dedicated effort in, then I think we have some great examples where we've had some sort of wonderful success. Our realization as a health system is that as much as we would like to sit back within our own organization and imagine inventing things, we're not really that good at executing. And so when we can sort of find a partner that is good at bringing that new product to the market, that's when sort of the real magic happens.
So both of your organizations, your universities, you're tied to have venture arms, and a lot of startups, of course, come out of your organization. There's a lot of startups in digital health. I've heard a lot of CIOs who say, I really have a hard time working with startups. They're small. I don't think they can scale. What are some of the pros and cons that you see of working with startup? Is that a feasible entity for an organization of your size to say, I'm going to work with them as a partner and view them as a long-term, able to scale solution?
For us, absolutely. In fact, so much so that we sort of brought sort of online sort of our own venture firm, really to sort of reach out to startups to sort of bring them back into the organization. Our thesis sort of around it was not necessarily to go and sort of capture the value of startups, although that would be wonderful if we have some sort of wonderful exits. The real idea behind it was finding unique ways to drive innovation back into the health system. And so our theory, again, was that we have sort of a little bit of a storied past of trying to create our own software. That didn't work out so well. And as we begin to go towards sort of the traditional vendor market and we look at health IT and we begin to sort of implement, we think we've done okay. We've probably put ourselves in the top 5, 10%, whatever sort of, that sort of high number might be. And when you sort of get to sort of that upper echelon, it becomes sort of more difficult to go and find sort of off-the-shelf things you can just buy and sort of implement. And so you're really left with sort of two choices. You can go and sort of innovate yourself, or you can sort of find the right partners. And what we found, and what we're frankly hoping, we're a little bit sort of early in the journey, is that if we can sort of bring in enough of these sort of startups and bring them early enough into sort of our mix and our conversations, we can really sort of inform each other. And so what we find a lot is that some of these startups that have really good ideas, certainly all the right entrepreneurial passion to sort of get sort of the right product going, they're maybe just off by 2 or 3 degrees. And the problem is being off 2 or 3 degrees, sitting sort of in an isolated sort of office or sort of accelerator sort of somewhere outside of the health system, by the time the product actually hits sort of our sort of clinical floor, that 2 degrees is now magnified and it could be off by sort of more than 50%. And so really what we're trying to do is to sort of not just sort of provide money and capital to some of these startups, but really sort of offer up sort of Cedars as a wet lab. Now the caveat is that there's really sort of a limit of how many of these we can sort of bring in. So our target is to bring in sort of a dozen or so, and sort of in any sort of given sort of yearly sort of cycle. And we're also trying to do it as much as we can with sort of a different mindset of the stereotypical hospital mindset would be everything needs to succeed. And so we're trying to sort of look at this with sort of a different lens of it's okay if some of this doesn't succeed, but we got to move on relatively quickly.
So you take more of that startup mentality and working with them as well.
We're trying.
Yeah.
I think I have a lot of respect for what Darren is doing. I think he said it well. I think he's really got a great system in place for this. We emulate some of that. We have an innovation program where we do intake, and we've talked to hundreds of startups and gone through a selection process to really evaluate those companies, provide some useful feedback to them, and then select a smaller number to do validation in our environment. A few thoughts about working with startups. First is that, healthcare and academic medical centers in particular are tough places to get deals done. I mean, there's just an enormous amount of complexities. There's lots of decision makers. There are compliance regulations. A lot of startups seem sort of startled by this when they come in to deal with it. Bigger companies have huge divisions that just manage through that, so it takes a little bit of patience. But that hasn't stopped us from being able to do this. The other thing I'd say is that a lot of people come to us and say, we want you to use our technology for free and help us validate it, right? And for us, nothing's free. We are a systems integration shop. We have 500 applications that we support, thousands of interfaces live, and that's what we really try to do well. So you bring a piece of technology in to validate it, and somebody's got to do a lot of work to introduce that into the environment in a way that you can actually learn something from it. Or you can just put it in as a standalone piece, but you're testing nothing about its systemness then. And so we're doing some work to try to structure that continuum, to say we can't always spend a ton of money to put this in a full-blown implementation, but we also have to be able to precisely define what a small pilot is and differentiate a small pilot from a lousy IT implementation, because often those two things get confused. And a small pilot means, among other things, we're going to take it out on a set date, go back and see whether we answered certain questions with it. The other thing is that people come to us a lot and say, we have a platform for you. We have a platform that you can use to solve a whole bunch of problems. There's only so many platforms you can have before they're not platforms anymore. And so we already have a few platforms, and we're very strategic about choosing platforms. We invest a lot of money in those baseline systems upon which all this integration is built. And that's not to say that we won't need more platforms, but we certainly don't need as many platforms as people think we do right now. And what we really want are modular plugins that we can put into our platforms, white label, and expose to physicians and patients in a way that doesn't feel complicated to them. We spend hundreds of millions of dollars getting our doctors to use an electronic health record, and we're not super keen on taking them out of that into something else. Or at least when we do that, we want it to feel like it's somehow integrated. And the same is true about how we expose these things, these new apps and technologies to patients in our portal. So that integration is hard to do. We're somewhat selective about doing it, and we love the solutions where they're not heavily dependent on that integration.
Okay. Of course, a lot of the Consumer Electronics Association and the CES show is around consumer-facing health applications. If you get on the floor, you'll see a lot of those. Many of them are targeting consumers. There's also obviously the hope that that information will either be contracted through a provider or filter into the provider in one way or another. What do you see as the future, either short-term or long-term, in terms of patient-generated data, the acceptance of that by clinicians, and actual bringing that into the IT system of a healthcare provider organization?
I had a little bit of a chance to sort of walk some of the show floor, and there's just an amazing amount of devices out there. Yeah. And it's sort of clear that the trend that we're in right now is sort of these wearables and sort of all of this sort of things that will gather information. My view on it is a little bit, I think, sort of different. I'm actually optimistic. I think that the devices will sort of work themselves out. I think you're going to have some sort of maturity in the marketplace. The big players will be sort of delivering some products this year. It'll sort of get probably a little bit more exciting as everything sort of gets amped up. And I think we will reach probably a tipping point of more acceptance of sort of all of this information. I think the challenge is, and the part that I think that will be specific to provider healthcare will be, I think, the next generation of products that will sit on top of this that my guess is we haven't exactly seen yet. And what I mean by this is that as the marketplace for gathering data sort of matures itself out, there's going to need to be something that sort of takes all this information, maybe normalizes it, maybe transforms it a little bit, certainly visualizes it sort of in new and exciting ways, probably adds some clinical decision support or at least medical intelligence to it, and ultimately sort of creates a more viable path by which providers can see the information. The story I'll sort of quickly tell is that we had a great vendor in, I won't sort of name names, so was very, very excited about sort of their device, and it really had some revolutionary ways of really providing information of what the patient was doing in their home. And one of our physicians sort of turned and said, it's interesting, but do I really care? And it's not that they don't care about the patient, but and I think the point that he was trying to make was that the information, the valuable data point isn't that the patient sat up in bed. The valuable data point is the trend of whether the patient's getting out of bed over a course of days. And so I think what I'm most excited about is, we're going through this period now where all these new devices will sort of get created. They'll sort of work themselves out. But I think the next layer of probably software that sits on top of that will, I think, really be when these technologies hit their stride in healthcare.
Applying some analytics or artificial intelligence to sort through the noise.
I hope so.
To the value. Okay, interesting.
It's exciting to see the marketplace. I agree. I looked at these and I said, wow, there are so many interesting new technologies. And I also noticed a lot of overlap and then also a lot of real sort of specialty niche applications. And I think we just need to be selective and careful about thinking about the difference between something that's incredibly appealing about improving your own health behaviors related to exercise. If you're into cycling and you want to be better at that, these are really cool devices. We should ask ourselves, is there really value in the intersection between that and the provision of healthcare as it exists today? And I think it's not quite there. But then there are these more generalizable things where we are closer to a problem that we want to solve. So we've had some discussions in this meeting about medication adherence as an interesting complex problem. It's always good when you can go back to the problem that you actually want to solve, and when the healthcare system can relate to that problem, then we're going to want to bring that data in and figure out how to solve it. Some of the vendors that I've seen, you can see the problem statement kind of even in the materials that are put up to see as you walk by. Others, it's difficult to get a sense of what the problem is, and in some cases that problem is generalizable and relatable to healthcare, and in others it's not. So I think this is, and I would just say I'm particularly enthusiastic about remote diagnostics, simplifying the process of diagnostics and getting it out of the traditional laboratory-based phlebotomy station. I think that's a problem we really do want to solve, and it's one of the ones that I'm excited about.
Okay, we've got 1 minute and 27 seconds left. What are any final conclusions or keys that you can say in terms of driving innovation within a very large, complex healthcare organization? What are some of the key hints or conclusion statements that you would make? Say, hey, you got to think about this, or these are the key things to success and innovation.
You know, I'm not sure there's sort of, you know, one sort of thing, but, you know, other than sort of some of the cliches of you just got to sort of keep trying and sort of accept sort of a bunch of sort of rapid failure until you can sort of, you know, find some of those innovations that will sort of rise to the top. I think the trick probably over the next few years, given sort of all the pressures and constraints sort of within sort of healthcare, will be sort of finding those things that really sort of offer a big enough bang for the buck. That really sort of, you know, hospitals and large health systems have a lot of friction to sort of enter them and sort of get your sort of product sort of installed. And so ultimately something that sort of has sort of a wide enough scope. And I think picking and choosing those probably will be sort of the secret in terms of those organizations that end up maybe sort of solving your pilotitis problem.
Okay, great. Thank you for helping with the cure.
Yeah, I agree. And I think at our organization, you know, it's sometimes even hard to talk about innovation because it's so diffuse and so much part of the culture of an academic medical center, and no one really owns innovation. So what we try to do is keep an inventory of what's actually happening, keep the right people involved, and no one wants to be working on something that isn't part of innovation. Who wants to do something that isn't innovated? So we want to mix it up, and I think what we try to do is say it's embedded. It's not like we have to put innovation over here on the side in order for it to work. We've got to put it into what we do every day, all the time. It's not easy because we have a lot of operational challenges that need to be solved every day, and that's, I think, the tension that we just try to manage all the time.
Okay, great. Well, thank you very much for your insights. We appreciate it. If we can
Yes, thank you.
pass it back to Jill.
Thank you very much.